Hello, my name is Guillermo Garcia-Manero. I'm a professor of medicine in the Department of Leukemia at the University of Texas MD Anderson Cancer Center, where I also serve as the chief of the section of myelodysplastic syndromes. The question is, what are priorities in myelodysplastic syndrome? So first, I would like to remind the audience that we tend to divide patients with MDS into four main buckets: low risk, high risk, and we use IPSSR to divide those patients, and then those that are treatment naive versus those that are what we call HMA failure. So basically, one group will be low risk untreated, low risk HMA failure, high risk untreated, high risk HMA failure. This is important because they have different natural histories, different prognosis, different needs. We've seen two recent drugs approved for our patients with MDS. We saw luspatercept for anemia in a subset of patients with lower risk myelodysplastic syndrome, and we saw the oral decitabine cedazuridine for patients with MDS that are treated with IV decitabine. But we need to do better than this. So let's start with low risk. In low risk disease, we need more powerful compounds to ameliorate transfusion needs and perhaps improve the natural history survival of our patients. So we have studies with the luspatercept in frontline. This is the COMMAND study. We saw the data from the Spanish group with the Sintra-REP trial of early intervention with del(5q) with lenalidomide for patients with del(5q) minus MDS. For sure, we need new treatment strategies for patients with lower risk disease that have been treated with an HMA failure. Our group and others have shown that these patients are characterized by a potent innate immunity kind of activation. So we're studying a lot of these pathways. And of course, we need to learn about how to incorporate these patients in this context. Transplant can be curative actually in this group of patients with so-called lower risk HMA failure. In high risk disease, we have two very different needs. We need to have better combinations that improve the survival that is expected with single agent azacitidine. There are a number of phase 3 clinical trials trying to address these questions. So we have the Verona trial with a combination of venetoclax. We have the ENHANCE trial in combination with magrolimab, the CD47 antibody, and we have studies with sabatolimab. We just recently heard bad news with the pevonidostat PANTHER trial and also with the APR study for P53 disease. So we still have 3 frontline major registration trials that hopefully will prove better than single agent azacitidine. And then perhaps the major need is for those patients that fail a hypomethylating agent. This is called HMA failure. Here we right now don't have much. We really need better agents and different ideas really to tackle this problem. And then finally, perhaps what some of us are starting to discuss is this issue of total therapy. And by that, we mean the following. So we're starting to have, for instance, at least in clinical trials, very good results with combinations of, let's say, aza-venetoclax, aza-magrolimab, and so forth. So we are able to induce very deep responses in our patients, but these patients still relapse. We also saw at the ASH meeting last year, published recently in JCO, really exciting results from contemporary data with stem cell transplantation in our patients. So hopefully these randomized studies in high-risk disease will translate into better results and more patients going into transplant, because now we can actually transplant older patients safer with better outcomes. And perhaps actually we need to put some thought in terms of what we do post-transplant in those patients at high risk for relapse. That's a total therapy. You know, identify the best therapy prior to transplant, perform transplant in the best situation possible, and then for those patients that need that, consider some type of maintenance post-transplant type of therapy. So I think that if we are able to cover these 5 things, better therapies for low risk, HMA failure low risk, new doublets in frontline, really where we are very in deficit is in HMA failure situation, and then this consideration of total therapy, we could start seeing improvements in survival in our patients. Thank you very much for your attention.